Okay, hey everybody, welcome back to our interview series. I'm Dr. Shaan from Vitality Chiropractic, and this is an interview series. We'll be talking to other health professionals, talking about their stories, how they got started, and of course, the people that they help. Today, our guest is Dr. Gurpal. Dr. Gurpal is an orthopedic surgeon practicing out of the Center for Orthopaedics at Parkway East Hospital and at Mount Elizabeth. Dr. Singh graduated from NUS in 2004 with a Dean's List Award and gold medal, then pursuing higher surgical training in Edinburgh. He specializes in orthopedic oncology, joint replacement surgery, and of course, sports injuries, particularly focusing on hip problems and surgery. Gurpal, how are things going?
Very good, Shaan. How are you keeping? Thanks for having me here.
No, it's a pleasure. Thank you for joining me. We're keeping busy, let's say it that way.
Good, yeah.
So for someone who's never been to see an orthopedic surgeon before, how would you explain orthopedic surgery to them?
Orthopedic surgery is like carpentry. We use the same tools. If you imagine a carpenter, we use saws, we use bone, we use screws, we use nails. It's just carpentry on human bones. That's one way to explain it. Of course, it might send a different signal to some people. Basically, I'm a doctor, and after doing my basic MBBS, I specialized in orthopedics, which is basically bones and joints. After doing orthopedics, I went on to do a subspecialization in joint replacement and robotic surgery. And I did another subspecialization in orthopedic oncology, which is the study of bone and soft tissue tumors or bone cancer. I also do sports injuries for the younger patients. And these are the three areas which I'm passionate about. But yeah, we deal with all forms of bone and soft tissue problems, from fractures to fixing of fractures to arthritis to joint pains. Yeah, that's why I called it carpentry. Yeah.
So if we start from the very beginning then, what made you decide you wanted to become a doctor?
Well, this is always, I was asked this question at my medical student interview, and when I think of that answer now, sometimes I feel a little bit embarrassed. I mean, every one of us says that, yes, we want to help people. It was a thought at that point in time, which I didn't even know what that thought meant. I just said it because it was the right answer to give for the medical school interview. But in times of crisis like this, during COVID-19, that thought takes a very different, I can see life in that thought. And now I know what it means to help people. The very act of coming to work every day, knowing that I'm not sure if I'm going to catch this from someone. Then when I come home, I have to distance myself from my family. It's not easy to get 6- and 7-year-old kids to keep away from you. When the wife doesn't understand why I have to sleep in a separate room. All these things are difficult, and I don't know. I'm putting myself at risk, but the idea is, if I go down alone. The family doesn't go down with me. They're not easy things to do, but it has to be done. And the fact that you don't feel I don't feel that this is a chore. Not even once has this thought come to my mind that I should not be going to work right now. I think that this is the life of that thought of helping people. It's a bit difficult to express, but I think I say this on behalf of all the healthcare workers who are out here. Some of my colleagues are in the front line. I know of some colleagues who have gone down at this point in time. And I think the very fact that none of us has had this thought even cross our minds even once, that I should just give this up and do something else, or I should just stay at home. I think that is a calling, and that speaks for itself. And I think it is only at times like this that we know the real meaning of why we wanted to do medicine. Yeah.
I think it's something a lot of people do talk about, of course, how thankful we are for people working in healthcare. And we talk about the long hours and dealing, of course, with the risk. But like you said, people don't think about the changes that means for your home life. Like you mentioned, I would say personally never thought about the idea of having to sleep in from another room from your partner. I've heard about people being quarantined, but not necessarily literally changing how their household is working. So it has a big impact. What was it that drew you most towards orthopedics then, rather than other specialties within medicine?
Yeah, so in orthopedics, as I mentioned earlier on, with the concept of carpentry, accuracy is very important. And somehow I'm drawn to that idea of accuracy and outcomes. So if you are accurate and you're precise down to that 1 degree, down to that 1 millimeter, your patient will walk out of hospital, without pain. The same patient in on a wheelchair will walk out of hospital happy with a smile on his or her face. But if you are not accurate, it's not forgiving. The outcomes will be bad, and you're talking about accuracy to that millimeter, to that degree. That's where robotics comes in, that's where technology comes in. And this very thought, among all the surgical specialties, I felt that this was the aspect of orthopedics that I was drawn towards. There is a potential for making a big difference, a huge difference in people's lives. And the concept of the challenge of accuracy drew me towards this specialty. Yes, just like a carpenter. I mean, if he gets that little foundation wrong, or that 1 degree error in the door, or the plank, or the building, or the beam, the whole building is at risk. And similarly in orthopedics, I feel that way.
You mentioned about the robotics. Can you tell us more about that?
Yeah, I was kind of hoping you won't ask me that, but now that you do, I'll have to be very honest with you. I think this robot is going to get me out of a job very soon, because it has been a humbling experience to start the journey of robotics. When I first started this, when I first went to Florida and I came back, and I thought that, wow, this is very nice, it'll help me improve my outcomes and all that. It was a humbling experience, because the very first case that I did, I thought I was right and the robot was wrong. But I was not right. And it just went on, and it streamlines your outcomes. Now I'll give you an example. Now here's a mobile phone. Now, when I say 40 degrees, what does it mean to you and me? Some people would say this is 40 degrees. Some people would say this is 40 degrees. And this is only in one plane. Now, if I say I want 30 degrees in this plane, what does this mean? So a lot of times we are working with what we call zones of safety, or concepts of zones of safety, where there's no way the human eye can reproduce a 30-degree inclination or a 40-degree inclination in, say, an acetabular cup when we do hip surgery. But we do know that from landmarks, we are within about 35 to 45, and that's a zone of safety. And a lot of times, that's what we work towards. Surgical experience will make us better and better in keeping within that zone of safety. But robotics has changed the game. Now, with robotics, I still open up the hip exactly the same way I would, but the concept of the zone of safety is not there. I've got a CT scan of the patient's hip fed into the robot, and I've done my planning before the surgery. And if I want 35 degrees, I get 35 degrees. So this conversation of zone of safety, am I accurate, looking at an X-ray and criticizing how could I have done better, all of these are now pretty much historical with this new technology. And it challenges your ego as a surgeon, because in the beginning, I thought, I can't be that much off. And I was. So every time I have been challenged, I'm usually the one that's wrong. So that's why I say that now I've become from an orthopedic surgeon, I am now degraded or demoted to an orthopedic technician. But this is the best thing that has ever happened in my career, because I am able to look at the patient in the eye and tell the patient, with this level of confidence, I'm going to give you this outcome. And I put my hands up and I say, I'm only doing this part of it. Of course, when things go wrong, I need to be able to bail myself out. I need to be able to do the surgery conventionally if the machine were to malfunction. And machines are machines, they can malfunction. So therefore, that surgical experience is important. But I think we need to embrace technology, and we need to embrace it in the right way, in the appropriate way. And with that, we can give our patients outcomes that we can only imagine or think about. 10 years ago, we could say, yes, in research and all that, we are seeing potentially this might happen. But now this is reality. And I'm quite convinced, maybe I am having very strong opinions on this, but I'm quite convinced that in the near future, we won't even imagine doing, say, a joint replacement without having that robotic machine. Of course, right now, there's a lot of controversy on this, and conventional methods are very, very good because surgeons are very, very good. But I think this is something that will change the game.
Yeah, I mean, I would say don't feel too bad. Think of yourself more like a manager rather than the technician.
Yeah.
But but yeah, I can understand it. I mean, it's the progress of the world. It's not just this; it's everything is starting to change. Not just to go, of course, within healthcare, but outside of healthcare too. I understand, of course, when you're working on this, you've worked on other parts of research as well. Is there any research that you're working on at the moment?
Yes. So the main research that I'm working on at the moment, and just before joining Center for Orthopaedics, I was with the National University Hospital. I'm still a visiting consultant, and I still feel very passionate towards academia. My main focus of research is, why do implants fail? You see, when we do a joint replacement, the ideal implant should last the patient's lifetime. We're not there yet. We still have this conversation. If you're too young, you might have a revision, or you might have a redo surgery when you are in your 70s or 80s. And that's a situation we want to avoid. So the entire focus of my research is, how do we avoid that situation? So we're analyzing the wear particles that come out of joint replacements. We are analyzing infections, how we can prevent infections. And I work with a team which is not just based in Singapore, but also from Germany. We collaborate, we have material scientists, we have implant companies, and we're looking at, why do people say, if you have a metal allergy and you have arthritis, then how do you get that knee replacement? What about people who become sensitive or hypersensitive to these joints? How can we reduce the wear in these joints? And ultimately, how can we make that joint replacement last for the lifetime of that patient? I won't say we have any answers yet, but it is very, very rewarding, this field of research. And hopefully within my career and within my lifetime, I will see that joint replacement that lasts a lifetime. Now, robotics is helping in a big way, because robotics is going to take away not all, but most of the human factors involved. So you're not going to be talking about the malaligned joint. Hopefully, again, in my career, in my lifetime, I see that this whole business of the joint was not properly placed to start with, or it could have been placed a bit better. These conversations hopefully won't exist anymore. Then we can focus on the wear, the material, and hopefully we can get better with that. So I think technology and both aspects are very complementary. Yeah.
So with regard to, say, something like a hip replacement then, what do you think are some of the main causes for that problem? If we exclude things like, say, an injury, if someone gets hit by a car, it's clear it's the car. But if it's, say, more lifestyle related, or even to some extent insidious, what do you think are some of the main causes that you've noticed throughout your career?
Yeah, so younger and younger patients. So if we take away, as you said, injuries, infections, malalignment from the surgery, if all of these things are taken out of the window, then one of the key trends that we are noticing is younger patients are coming forth and asking, I need the replacement. I don't want to wait until I'm 60. I don't know what's going to happen. Now I'm 45. I don't know what's going to happen in the next 15 years. I want my life right now. I want my quality of my life right now. So do something for me. And that's where we have this dilemma. Should we be waiting, which is the old school conventional approach? Should we waiting until patient is within that range, so that hopefully we don't have to revise this patient within, now we are working with statistical probabilities here. Or are we going to say, okay, you know what? I agree with you. I give you that quality of life now. But what is this patient going to do then? Of course, he's going to be more active. He or she is going to be more active. He's going to put that new hip replacement through a lot more stress and a lot more wear. Patients want to do sports. And, there are people who do some level of sporting activity with hip replacement. So that's where we are challenged even further. Technology and materials. And of course, the human input. We have to come up with something which is not just longer lasting, but it can take all these extra demands as well.
Yeah. What do you think are some of the causes then? Because I mean, say if somebody has bilateral hip replacement for some reason, that could make sense. Like you mentioned, something like an infection. But if it's something unilateral, especially if people are getting younger as they're having these problems, what do you think are the triggers or instigators for this problem?
Which problem? The problem,
Say hip replacements or even knee replacements when not caused by injury.
as in the failure of the joints, or
Yes.
the
Yeah, for the original joint, not for the replacement.
the failure of the original joint, generally speaking, is due to arthritis. And if you are talking about younger individuals, sometimes it's due to inflammatory causes like rheumatoid arthritis, gout, and other forms of disease where the immune system attacks the person's own joints. It could be due to a previous injury, as say an accident that was there 15 years ago. It also could be due to other problems such as a malalignment between the socket as well as the cup. Now, if we imagine, I don't have a model with me right here. Yes, I do. Now, here we are. So this is the hip joint. As you can see, this is the ball and socket. Now, if there's a malalignment between, if the socket is too shallow, we call that condition hip dysplasia or dysplastic hip. And if that is shallow, you will get early arthritis. If the cup is if it's covering the joint too much, that's also a problem. So nowadays we are screening most of our babies when they're born with ultrasounds. But in, say, your generation and mine, or even people who are a little bit older than us, there was no screening at birth. So we are seeing some of these patients manifest as early arthritis in their 40s, for example, some even in their 30s. And they need hip replacements at an early age, otherwise they're in severe distress.
Do you think there are any lifestyle factors which may be acting as further triggers for this?
Yeah, so lifestyle factors definitely. I think in affluent societies, obesity is a big problem, and I think obesity is something that we have to manage. So the logic is simple. The more load there is on the joints, the faster the joints wear out. So that's a big problem we're having to deal with, especially in affluent type of societies. Yeah, that's, well, it's a chicken and egg situation. Yeah.
Kind of a difficult one to kind of solve. How people eat better, sit for less time, but then that's also part of their whole lifestyle. Yes. It's kind of hard to accomplish.
Yes.
So I understand that for some people, after not just, again, joint surgery, but for general surgeries, there can be some changes in sensitivity. Could you explain to people why that may be?
Sensitivity in what sense?
Either hyper, or sometimes allodynia, you know, this altered sensation.
Okay, so when we do joint replacement surgery, there are very fine, tiny nerves in the skin that can potentially be cut when we do the surgery. We're not talking about the major nerves of the limb, like the sciatic nerve and all that. I mean, those clearly, we have to preserve them and we have to take extra care to make sure that they're not injured. But the very fine nerves, some of them which are even tinier than hair, sometimes will get cut. We call them cutaneous nerves. And when that happens, the nerves will regenerate. It's like a bunch of electrical wires that are, the circuit is forming back. When that happens, sometimes there will be reduced sensation over the wound area or around the wound area. Usually this recovers. A small minority of patients do get hypersensitivity. And at the extreme of that, we call it complex regional pain syndrome. Fortunately, it's a very small minority of patients who end up with that problem, and usually responds to desensitization measures and medications. So while these problems are real, I think it's important that we recognize them early and we counsel the patients early, even before surgery, so that we can manage them appropriately. And if there are signs of any of these things happening, the earlier we catch it, the better it is. Yeah.
I understand, of course, you work in oncology before. Do you still see a lot of cancer patients now?
Yes, oncology is my specialty, and in addition to joint replacements, I do orthopedic oncology, which is the bone and soft tissue cancers, and I subspecialize in limb salvage or saving the limb, complex reconstruction. So we have moved. This is an evolving specialty, and we've basically moved from amputation towards limb salvage in the last couple of decades, I would say. In this specialty, we're pushing the boundaries. Now, limb salvage has become the norm rather than an exception for these cases. It's a challenging specialty where we have to work as a team. We have the oncologist, the radiation oncologist, the radiologist, the pathologist, the surgeon, the physiotherapist, the allied health nurse, and we all have to work together and make sure that these outcomes are achievable. So I'll give you a typical example. A lot of bone and soft tissue cancers happen in young people, often in the first to second decades of life, and it's a tough journey to walk. So a recent patient that I treated, 21-year-old boy, osteosarcoma of the proximal tibia, which is the leg bone. So he had to go through chemotherapy for 12 weeks. Then we resected 19 centimeters of the leg, and including the knee. And we replaced this with a prosthesis. We took a muscle, his calf muscle, and we covered the prosthesis. And this whole surgery took 6 to 8 hours. And after that, he had to go through another 12 weeks of chemotherapy. But he has done very well. He's back in university and in a hostel. I keep telling him, don't run on this, but he doesn't listen. So he's disease-free. And when we get outcomes like this, that's the best reward you can get. But it's a lot of work. And I can't take even 10% of that credit on my own. It's the team. And that's where I think, you've seen some of the patients and the queries that I've sent to you, like, can you help them a little bit move, get them moving a little bit more? And that's why I say physio, chiro, you guys are more important than the surgeon, I would say. So you really need to, because after I replace the limb, or I save the leg and I do whatever I need to do, the oncologist does the chemo, but the rehab is done by you guys. So I think often the layman or the lay people, they forget that. And I keep telling the patients that the rehab is as important, or if not more important than the surgery. So it's a team effort. It's really a team effort.
You mentioned before about, say, some of the patients, which, every healthcare person experiences this, maybe not always listening to advice. What other challenges do you generally find with patients?
Not listening to advice is common, but I think it all comes down to the relationship and the rapport that we have with them. So I think once you have developed close rapport with patients, hopefully this can be overcome. Most of the time it does. It does. Even I sometimes have little arguments with them as well, but they're friendly arguments. And when they're in their teens and when they're in their 20s, sometimes it's hard for them to listen to me. And then I would tell them about some of the silly things that I used to do when I was at that age, and then they come closer to you, and the little ways of doing it. But yeah, that's a real challenge in some of these patients. Apart from that, I think one of the major problems is when I'm talking about arthritis patients now, like patients with joint pains. One of the biggest problems is seeing a doctor early, because for all the public health talks and all that I do, this is the main message that I have. Please see early, because in our society, one of the biggest problems is that we tend to neglect joint pains and all this kind of stuff as, oh, this is nothing much, this is part of growing old, and I'm only going to see a doctor when the car really breaks down and then I need a tow truck. So that's perhaps is the main thought process that I'd like to, if I had my way in an ideal world, I'd like to change that. Because The earlier you come, the less work we have to do. The smaller the surgery. Most of the time, you don't even need a surgery if you come early enough. And whereas if you come when things completely break down, then you need a major overhaul or a knee replacement. And even the knee replacement gets more complicated the more deformity you have. So I often look at, before COVID, for example, when I'm having a meal in the coffee shop, I mean, being an orthopedic surgeon, I have this tendency to look at people's knees and legs, and I mean, look at some of the, like the senior folks, they've got really bad deformity, and I wish I could just tell that uncle or auntie, you need a knee replacement, and let me just sort that out for you. But of course, I'd keep that thought to myself at that point. But yeah, I think we need to change that behavior because it affects their health in many ways. If mobility is reduced, your chronic conditions like diabetes, high blood pressure, heart problems, all will become worse because you will be more sedentary, you will not be exercising. If you're taking pain relief medicines daily, that will have a toll on your stomach and your kidneys. So you see, these hidden effects are not seen by people. And when we see them, we often see them when a lot of damage has already been done. That's something I wish for every day. Yeah.
I mean, yeah, prevention is one of the biggest things. And to some extent, this may be one of the advantages of COVID now, hopefully, that we can take away from this, because so many people are being tested that thankfully are not as extreme symptoms as some others. So at least it's still instilling this idea. Yeah. As well as prevention, are there any other changes that you would like to see implemented into healthcare systems, either here in Singapore or even in other countries? Or do you think would be beneficial?
Yeah, I think honestly, we are very, very, very fortunate here in Singapore. Especially with COVID, I think this realization has become very stark. And I think every time we complain, we should look at ourselves, get some perspective before we, when we compare our scenario right now to the rest of the world, I think there is really no room for complaint here because we are very, very fortunate. Perhaps when I think in a very idealistic manner, I do feel that, if in today's world we could be a little bit more connected with the rest of the world, imagine if we all were one big healthcare system, and sitting here in Singapore, if we could help some of the countries where resources are a problem and that sort of stuff. And close to my heart is, in my own specialty, I'm seeing a lot of cases, not now during the COVID system, but the COVID problem, but just before the COVID problem, 30-40% of my practice was from overseas, from regional patients. And I used to go to the regional countries at least 4 or 5 times a year to do charity work and to teach the local doctors on how to do some of this stuff. And this is mainly to do with the cancer work. Because we only have one bite at the cherry, and a lot of times the patients we were seeing were either offered amputation or surgery had been done by, in the context where the relevant expertise was not available and the margins were contaminated. And imagine a 12-year-old patient sitting in front of you with a cancer that has been partially removed, and you're now stuck where you could have offered a limb salvage or saving the leg. You have to amputate this child now, or even worse, where the cancer is now spread to the lungs and you can't offer him a cure, and you have to tell him, look, it's very painful to tell the parents that, very, very painful. Especially when, we have kids on our own, we understand how it is, when your child is sick. So I think hopefully if we can be a bit more connected, and I actually do feel that we can be, one of the lessons we've learned over COVID is there's so much we can do over Zoom and over webinars and all that. And so we're reaching out quite a bit in our own little ways to, in our own specialties to, I think it's very selfish if we have a certain amount of knowledge and skills. I think we are lucky that those skills were given to us by society, and we have to do our payback. We have to give those skills back.
You mentioned about charity, and charity is something that's very dear to me as well. How did you get involved with some of these other outreach programs?
I've often been asked this question, but I've never really found an answer. It just happens. I've done nothing to make it happen. To be honest, I can't take any credit for any of this stuff, because I see it as a blessing, as something to be grateful for, that, you know, makes it actually contributes to sleeping better at night. Because you say the regional charities, it just fell in place. You know, I was having a conversation with someone in Sri Lanka, and because I used to travel there quite regularly at the invitation of the Sri Lanka Orthopaedic Association, and it just happened. He just said, you know, can you see some patient? You know, it was informal because they just needed some advice, and the patient's father then linked me up with some, you know, and then before I knew it, I mean, I'm working with the local doctors in education, and, you know, we're seeing patients who can't afford to come to Singapore, and the same thing happened in India, the same thing happened in, you know, Vietnam, the same thing happened in locally as well. I mean, I work with, I'm part of a grassroots, I am a grassroots leader, and I volunteer, or I give talks at various platforms, and I work with the various community groups to, you know, do charity clinics. And before COVID, I was doing that once a month, and it just happens. You'd be surprised. Up with everything going, yeah. Did I lose you for a minute? Yeah.
Yeah, just for about maybe 10-15 seconds there. Yeah.
Yeah. So I was just saying that, you know, locally I volunteer on the grassroots platform, and I work with some of the community groups to run some charity clinics once a month for the less fortunate among us, and it just happens, you know, like there are so many good-hearted individuals and volunteers out there who just come together and make it happen. And, you know, we have different venues we take every month, and we are doing, we're seeing, of course, I try to see mainly patients with bone and joint problems, because that's where I can contribute the most. But of course, during COVID now, I mean, our hands are a bit tight, and we are trying to do as much virtually as possible. But that was certainly a part that I enjoyed the most, and I hope it'll come back soon, because I mean, it's a commitment to give about 20% of your time to charity, and I think the rewards are not something that I can describe. Yeah.
You mentioned before about, of course, doing more things, say, over Zoom and online. For people watching this, what kind of advice would you give them if they're at home, whether it's working from home or if they're not able to see their physician because it's only essential services at the moment?
Yes. So clearly, for people with essential problems like heart problems, you know, diabetes, chronic disease, and patients with cancer, I think all of these are essential services. And my colleagues, I know that all of my colleagues are working, and they're treating all of these conditions. And I think it's important that while we are treating COVID, we must not be over neglecting, from the patient's perspective, these essential health problems. I mean, it's important that because it's the fear of COVID can sometimes result in a situation where a patient neglects his or her other problems. And I think that is something that should not happen. We should be having perspective. You know, our government is doing a lot, much, you know, as I say, I mean, I'm not very good with words, but I think we are very, very fortunate that we are here. We're having these conversations, and I think we should not be neglecting our other problems. We should be eating healthy. We should be giving some due attention to exercise and keeping active. You know, weight gain is a big problem during this situation. So I think, yeah, I think with regards to COVID, there's very little more that I can contribute, because there's already so much going on, and, you know, we have our government, a task force is already doing everything. All I would say is, please listen to the government. Please stay home. Please listen, because we are not doing this for anyone else. We are not fastening a seatbelt because we don't want the policeman to catch us. We are fastening the seatbelt for our own safety. So that's the main message. Please cooperate with the government. Please do what they're saying, because we're very, very fortunate to have guidance like that. Now, with regards to the other medical problems, we should not be neglecting them. We should be doing our part to stay healthy, keep our immune system healthy, and we should be exercising, keeping active. And I think mental health is the other issue that people are, feeling different strains and different forms of stress. I think we must pay due attention to that, particularly vulnerable groups like children and elderly. We must try to communicate and look at their needs, and sometimes just be there for them. Yeah.
Yeah, I agree, absolutely. So before we go, because I know you have more patients, because I've actually caught you between patients today. If you could talk to yourself, say 5 years ago, and give yourself some advice, what kind of advice would you give to yourself?
To myself, you see, I belong to that category of people that you earlier said, that don't listen to advice. But yeah, I have been, the advice I would give myself is, I was fairly resistant in embracing technology at one aspect in my career, at one point in my career. And, as with many of us, sometimes we feel that, there's this resistance to taking on new technology and things like that. I wish I had done that a little bit earlier, in fact. Because now what I'm seeing is the huge impact and the positive outcomes that I'm seeing in my practice. I just wish I had done that a bit earlier, and had not been so stubborn in terms of not embracing this technology. But thankfully, the stubbornness was broken, and now I keep telling all my friends and colleagues, and we must be open, because we must be open to medicine. Is no, especially when I teach students now, I tell them, I said, just think of what you're going to be in 10 years. If you do not embrace technology, if you think that you're going to do without it, I think we're being short-sighted. Yeah, I think technology is there for us, and we have to have a harmonious marriage with technology, and then we can offer best clinical care to our patients. Yeah.
It's a very humble way to overlook that resistance and the as you mentioned yourself, the technician role and how things may change in the future.
Yeah, but that's honestly how I feel about it. Yeah.
Well, thank you very much for joining me today. I really appreciate it. I know that you're still going to be very busy even in these difficult times.
Thank you, Shaan, and I hope we are able to catch up in person soon once the circuit breaker is over. Yeah, and I think let's continue to deliver what we can, do what we can, and deliver the best care for our patients. Yeah.
Absolutely. I just want to say thank you, of course, for joining me. Thank you for everybody who's watching this either live or watching this on the replay. If you have any questions, I made sure that Dr. Gurpal and the Center for Orthopaedics is tagged in this post. So you can, of course, contact them if you have any questions about something for your own health. If you have any questions for me, of course, you can leave them in the comments, or you can email help@vitalitychiropracticcentres.com or call 8438-9550, and we'll make sure that we get back to you. Again, thank you for joining me today, Gurpal. I really appreciate it.
Thank you, Shaan. Take care.